Welcome, and thank you for participating in the Foundations of Infant and Early Childhood Mental Health training provided by the Georgia Association for Infant Mental Health Birth to 5, also known as GA-AIMH. As part of the training, you will be asked to complete a brief survey before and after the video that will include questions about the content covered in the training. In order to receive your certificate of completion, you will need to complete all of the training requirements, including completing the pre-training survey, watching this training video, and completing the post-training survey. Prior to watching this training, you should have already completed the pre-training survey. If you have not done so yet, please pause the training video and complete the pre-training survey, which can be found at the following link. This training is being offered through the Georgia Association for Infant Mental Health Birth to 5, also known as GA-AIMH. The vision of GA-AIMH is for all Georgia's infants and young children to be safe and nurtured through consistent caregiving relationships in order to reach their fullest potential. We aim to do this by supporting a range of early childhood professionals who address the social, emotional, and developmental needs of young children and their families. If you would like more information about GA-AIMH or to sign up for our contact list where we provide updates and information about relevant training, consultation, and resources, please visit our website at www.GA-AIMH.org or email us at aimh@gsu.edu and follow us on Twitter at GA-AIMH. During this training, we will provide an overview of infant and early childhood mental health and discuss several IECMH specific approaches to care across the spectrum of services as well as current initiatives in Georgia. We will begin this training with an overview of infant and early childhood mental health, including defining infant and early childhood mental health, describing infant and early childhood development, understanding the impact of stress, trauma, and adversity on the developing child, and identifying those protective factors that can build resiliency and support infant and early childhood mental health and wellness. Infant and Early Childhood Mental Health, or IECMH, refers to the developing capacity of the child from birth to 5 years old to experience, manage, and express a full range of emotions, form close and secure interpersonal relationships, and explore and master the environment and learn. The development of these capacities are all considered within the context of the caregiving environment that includes family, community, and cultural expectations for young children. The process of developing these capacities is often synonymous with healthy social and emotional development. Importantly, infant and early childhood mental health sets a strong foundation for mental health and well-being across the lifespan. Infant and early childhood mental health looks different depending on the age and developmental level of the child. While there are a lot of factors to consider when we talk about social and emotional development, such as a child's culture, developmental level, and experience, we will review some of the typical social and emotional milestones across each of these ages. In the first several months, an infant takes their surroundings through their senses: touch, sight, sounds, smell, and taste. As newborns, infants already show a preference for their parents' smell and can be comforted through calming voices, touch, and smell of their caregivers. Before they are able to purposely move their arms and legs, they can follow movement with their eyes, such as watching their parents as they walk by. Crying is common in the first several months, peaking around 6 to 12 weeks. Caregivers can typically comfort and calm their newborn by decreasing stimulation, using soothing sounds and touch, swaddling and holding, gentle rocking, offering a pacifier or other safe objects to suck, and ensuring their needs are met, including sleep, feeding, and a clean diaper. There are other times when a baby may continue to cry, which can be upsetting for a family. It is important to make sure a caregiver is also taking care of themselves. 0 to 3 advises parents to remember that caring for a crying baby can be very stressful, so it's important to take the time needed to calm yourself in order to better care for you and your child. Between 6 and 12 months, a child is learning more skills to explore their environment through reaching, rolling, and crawling. They are beginning to understand basic cause and effect. They are quickly developing more skills to actively engage with others. They begin to enjoy more socially oriented games such as peekaboo and looking at their reflection in the mirror. Their repertoire of sounds and facial expressions are expanding, and they will use smiling, crying, laughing, vocalizations, and pointing to make their needs known and to express their feelings. Babies at this age often begin to cling to familiar adults and may cry or be shy when separated from a caregiver. After the child's first birthday, they often begin exploring their environment more independently while still checking in with their caregivers. They may be more likely to try new things, which is especially important to remember when ensuring their environment is safe for them to explore. Between 12 and 18 months, many children begin to use words to communicate their needs and interests, such as pointing to a toy and saying car and asking for more. Socially, they may try to actively engage with caregivers, such as by pointing to toys or bringing their parent an object of interest. Children at this age will also start to become more aware of and interested in other children. Caregivers may start to notice a wider range of emotions, such as happiness, surprise, fear, or nervousness, and tantrums. These are big feelings, and young toddlers often need support from a caregiver to regulate their emotions. By 2 to 3 years old, a child has developed many of the cognitive, language, and motor skills they need to better navigate and understand their environment. Children are becoming more and more independent and may show defiance as a means of practicing this independence, such as saying no or doing what he or she is told not to do. Children move from playing near other children to engaging with other children in play. They better understand and enjoy back and forth games and may enjoy helping adults with small chores. Many children may have an easier time now separating from their parents and often do well with routines and predictable schedules. The 2 to 3 year old child has a range of emotions similar to adults but will still need support in identifying and regulating their big feelings. The 4 to 5 year old child has an even more sophisticated understanding of social and emotional interactions. Not only do they have a range of feelings now, but they can also name their feelings, understand what experiences trigger different emotions, and know better how to regulate their feelings. They can play cooperatively with other children and navigate solutions to conflicts. Relationships with peers become increasingly more important to them, and they may want to please, imitate, and be like their friends. Many children at this age show dramatic growth in their creativity and enjoy singing, dancing, and playing make-believe. Their growing independence can often be demonstrated through both demanding and cooperative behaviors. There are a number of early indicators of mental health concerns in infancy and early childhood. These depend on the age and developmental level of a child. From birth to 3, some behaviors that warrant additional follow-up include, but are not limited to, consistent difficulties with sleep or feeding, often irritable, incessant crying, or unable to be consoled, unable to adapt to new situations or people, upset by everyday noises and routines, difficulty engaging with and forming relationships with other children and adults, excessive hitting, biting, throwing, and pushing, withdrawn behavior or flat affect, shows little to no emotion at all, frequent somatic complaints, or caregiver disengagement with a child. As a child reaches the preschool years, between 3 to 5 years old, many of the concerning behaviors relate to social interactions with others and emotional regulation. Among others, some behaviors that warrant follow-up include when a child engages in repetitive and restricted activities, such as play enacted in a specific order, behavioral outbursts and tantrums that are excessive in amount, duration, and severity, withdrawn behavior or flat affect, shows little to no emotion at all, shows limited engagement with others or interest in social interaction, displays repeated aggressive or impulsive behavior, difficulty playing with others, frequent somatic complaints, limited or lack of language and communication directed at others, loss of earlier developmental achievements, appears anxious or fearful in many situations, or caregiver disengagement with child. Caregivers who have concerns with their child's behavior, development, or well-being are encouraged to talk with their child's doctor, teacher, or other trusted professional who can help the family navigate supports. Now that we understand more about what infant and early childhood mental health is and what it looks like across the ages, let's discuss how infant and early childhood mental health develops. It is important to consider the risk and protective factors from the perinatal period through infancy and into early childhood. While some factors remain consistent across the spectrum, such as access to appropriate nutrition, other considerations are more influential at specific times. The perinatal period is considered the time from pregnancy, delivery, and through the first several months after birth. An incredible amount of development and attachment occurs during these important months, both for the child and for their family. Infant and early childhood mental health begins before a child is born. The perinatal period is considered the time from pregnancy through the first several months after birth. An incredible amount of development and attachment occurs during these important months, both for the child and for their family. For the child, the first environment in which the brain develops is prenatally, where the fetal brain progresses from a neural tube to gradually developing features of the adult brain over the span of about 9 months. Adequate prenatal care and nutrition are essential for healthy development during this time. Additionally, the caregiver-child relationship is already starting to develop. Before a child is born, many parents begin to imagine what their child would be like and can express hopes and desires for their child. Caregivers may begin interacting with their child, such as by talking and singing to them. The bond and attachment between the child and caregiver continues to grow through these interactions. In addition to the vital development of the child's brain and other organs, the family also goes through an extraordinary range of growth and development. There are those concerns and stressors common to most growing families, including normal experiences of stress, doubt, uncertainty, and concerns for future planning. Above and beyond these typical concerns families navigate, many families also experience more significant perinatal mental health concerns. 1 in 5 women are diagnosed with a mood or anxiety disorder during the perinatal period, and many others experience non-clinical levels of stress, anxiety, loss of control, and depressed mood. Overdose and suicide is identified as one of the leading causes of maternal death during pregnancy to 1 year postpartum. Similar to preconception rates, intimate partner violence occurs in 6 to 9% of pregnancies, leading to an array of other risk factors, such as lack of access to nutrition and quality prenatal care, increase in maternal stress, anxiety, and depression, and impacts on the baby, including higher risk for preterm birth and low birth rate. For most families, the perinatal period brings about an additional layer of financial hardship, with 24% of women reporting unmet healthcare needs in the perinatal period and 60% reporting healthcare unaffordability. Each of these areas and statistics is exacerbated for women who live in poverty, have a single relationship status, are younger, and who are of a race or ethnicity that is typically underserved by systems of care. There are many risk factors as well as protective factors during the perinatal period for the child and their family. Risk factors include, but are not limited to, exposure to prescription and non-prescription substances, maternal infections and illnesses, stress, trauma, and adverse events, depression, anxiety, and mental health concerns, lack of access to prenatal care, lack of access to adequate nutrition, congenital anomalies in fetal brain oxygenation, stigma associated with accessing services, no insurance coverage, and no paid parental leave. Protective factors include, but are not limited to, routine prenatal care and access to adequate nutrition, mental health services and psychoeducation support for families, social and community support, family planning services, screening for perinatal mental health concerns, integration and co-location of perinatal services, broader reach of types of clinicians trained in perinatal mental health, Medicaid expansion through 12 months postpartum, and paid parental leave. Once a child is born, the brain continues to develop rapidly, reaching about 90% of its adult volume by 6 years old. In addition to growing in size, the brain is also forming neural connections essential for learning. In the first few years of life, more than 1 million new neural connections are formed every second. Early experiences and environments influence the neural connections that are formed and can also influence whether, when, and how genes are expressed by laying a foundation for future development. In addition to impacting brain development and neural connections, early experiences can also influence the expression of genes that a child has inherited from their parents. This concept can be summarized by a relatively new field of research called epigenetics. Epigenetics demonstrates how environment influences and actually changes the expression of genes. Importantly, epigenetics can explain how early experiences can have lifelong impacts. A child inherits genes from their biological parents, which guides their development. However, the actual expression of these genes is modulated by experiences across development. Both positive experiences, such as supportive relationships, and negative experiences, such as stressful circumstances, can determine if and how a gene is expressed. Epigenetic changes begin before a child is born and span across their life. However, young brains are particularly sensitive to epigenetic changes and lay a foundation for all future development. We may not explicitly remember many of our experiences before age 5, but our bodies, genes, and brains do. These biological memories, as they are sometimes referred to, can impact various organ systems and influence physical and mental health outcomes, as well as create a foundation for future learning capacity and behavior. Taken together, this means the brain development is greatest in early development and most susceptible to environmental influences. A child's environment and experience in these first 5 years can establish either a sturdy or a fragile foundation for all of the learning, health, and behavior to follow. There are different levels of stress and adversity experienced by young children, and each of these has a varying degree and type of impact. Positive stress response. Not all stress is bad stress. Some help us grow, develop, and learn. Normative and developmental appropriate stress results in brief increases in heart rate and mild elevations of hormone levels. Importantly, positive stress is not only normal, but it is an essential part of healthy development. It facilitates a child's learning about regulation and sets the stage for a lifetime of emotional awareness and regulation and navigating new situations. Examples of positive stress in infancy and early childhood include receiving immunizations at the pediatrician's office or when a parent drops a child off at a new childcare. The response is typically brief, and regulation can be facilitated by a caring adult. Emotionally costly stress, also sometimes referred to as tolerable stress, is the response to more significant stressors that activate the body's alert systems to a greater degree. These responses are typically the result of stressors that are more severe and/or longer lasting. Examples include a parent who is dealing with a significant illness, experiencing an accident or natural disaster, or a more serious injury like falling off of the playset and breaking an arm. When these events are time limited and young children have strong relationships with adults who can help the child regulate and adapt to their stressor, the child is more likely to be buffered from the potential long-term damaging impacts, and the developing brain and body systems are more likely to recover. Toxic stress refers to when a child experiences stress and adversity that is strong, frequent, and/or prolonged. Examples include physical or emotional abuse, chronic neglect, caregiver substance abuse or mental illness, repeated exposure to systemic racism and/or stressors associated with economic hardship. When these are coupled with inadequate adult support, this leads to prolonged activation of the stress response systems and can disrupt brain and other organ system development, leading to increased risk for negative social, academic, and health outcomes across the lifespan. Adverse childhood experiences, also known as ACEs, are traumatic events that occur before a child reaches the age of 18. ACEs include types of abuse and neglect, as well as other environments and situations that may cause trauma for a child, such as having a parent with a mental illness or who is incarcerated or being part of a family going through a divorce. Toxic stress can lead to underdeveloped neural connections in areas of the brain that are essential to learning and education, such as the prefrontal cortex and the hippocampus, which are critical for memory, learning, and the executive functioning skills that are essential in schools, workplaces, and relationships. We also see an exposure effect with adverse experience. The more adverse childhood experiences, or ACEs, a person experiences, the more likely they are to have developmental delays, poor health outcomes, lower graduation rates, and decreased academic achievement, and more likely to engage in behaviors that further impact well-being and health. In Georgia, there are many children who have experienced at least one ACE. For example, 9.5% of Georgia children had a guardian with substance abuse, 10% had a parent serve jail time, and 21% live in poverty. Fortunately, as Dr. Carl Bell said, risk factors are not predictive factors because of protective factors. IECMH offers a way to prevent and mitigate the impact of stressful, adverse, and traumatic events, as well as build strong social-emotional well-being. Let's look closer at the protective factors in infancy and early childhood. When we think about how to support infants and young children, we must always consider the fact that infants and young children exist in the context of their relationships with others, their family, caregivers, community, and culture. It is only in the context of the relationships they have with others that we can understand and support the mental health and well-being of infants and young children. So what can we do to help build resilience, coping skills, and well-being for children that can last a lifetime? Just as the developing child is susceptible to the negative and impact of stress and adversity, so too are they primed for positive development and well-being. The experience and impact of early childhood adversity and toxic stress can be prevented and mitigated by implementing practices that strengthen relationships, reduce sources of stress, and build core skills of young children, their families, and the communities in which they grow. The more that is put towards building resilience, supportive relationships, and social-emotional development early, the more likely a child can have the tools and relationships they need to learn, build healthy relationships, and make those decisions that will lead to a more healthy, happy, and successful life. The Center on the Developing Child at Harvard University has identified 3 key principles to improve outcomes for children and their families. These key principles are 1. Reduce sources of stress, 2. Support responsive relationships, and 3. Strengthen core skills. As we discussed previously, toxic stress, adverse events, and traumatic experiences can derail healthy development. By reducing sources of stress for both children and their families, we can help promote a safe, consistent, and nurturing environment. The Center on the Developing Child states, a multi-generational approach to reducing external sources of stress on families has double benefits. It clears the way for adults to provide responsive relationships and stable environments for children, and it helps children to develop healthy stress response systems and sturdy brain architecture, to focus on learning, and to receive a lifetime of benefits from these early building blocks of resilience. There are many protective factors that can be promoted by the IECMH workforce to reduce sources of stress for young children and their families. Some of these approaches include advocating for and enacting policies that make sure families can meet basic needs, such as affordable housing, quality education and childcare, medical coverage, mental health services, and nutrition. Simplify and streamline regulations for accessing benefits so that families have more consistent access to needed services. Integrate an assessment for potential stressors into the intake process and dedicate time during visits with families to check in on potential stressors. And support the workforce through reflective and supportive supervision, manageable caseloads, and skills development so that they can better support families and their own well-being. Responsive relationships build sturdy brain architecture, support overall well-being, and buffer children and adults from toxic stress. According to the Center on the Developing Child at Harvard University, the most common protective family for children and teens who develop the capacity to overcome serious hardship is having at least one stable and committed relationship with a supportive parent, caregiver, or other adult. One way to help support responsive relationships is to increase continuity of care and services for families. Factors such as loss of a child care subsidy, housing instability, or involvement in the child welfare system can interfere with consistent and stable relationships. By providing benefits to help families consistently meet their basic needs, as well as enacting flexible program guidelines that allow families to remain connected to services, we can help prevent families from cycling in and out of programs. We can also help promote responsive relationships between children and their caregivers by enacting policies and programs that strengthen and preserve the family relationship. Whenever possible, families should be supported in remaining unified. In situations where a child is in out-of-home care, changes in placement should be minimized, and there should be frequent contact between the child and their caregivers and siblings. Support should be provided to caregivers who are incarcerated or facing housing insecurity to remain involved in their child's care and well-being. When needed, families should have access to evidence-based, relationship-centered dyadic therapy that strengthen the caregiver-child relationship, such as child-parent psychotherapy. Finally, it is important that the workforce is also supported. This includes adequate compensation and benefits, access to supportive supervision and emotional support, and professional development to increase competence and confidence in providing high-quality care. These services should be integrated into organizations and individuals that are trusted within the community whenever possible. Core skills refer to those skills that lay the foundation for all other learning and functioning. They include skills such as executive functioning, self-regulation, and social-emotional skills. In early childhood, these skills include teaching children to focus their attention, respond to limit setting, and following simple rules. As a child gets to preschool years, core skills are integrated within creative play, where children must learn to adjust to different rules, be flexible in their thinking, shift their attention between others, and inhibit impulsive behaviors. These skills are necessary in order to build strong, healthy relationships and learn academics and other essential life skills. Core skills such as executive functioning and self-regulation develop rapidly in the first several years of life, but they can continue to grow and strengthen across the lifespan. Some ways that we can help children and their families develop and strengthen core skills are by modeling explicitly teaching and practicing core skills in developmentally appropriate ways. For young children, this often takes place in the context of play. We can also implement two-generation programs to strengthen core skills for both the child and caregiver, and also teach and coach caregivers how to continue to develop their child's core skills outside of the program. It is important to advocate for the importance of including the teaching of core skills across educational settings. When teaching core skills, it is important to build upon the skills that people already have and create opportunities to practice skills in everyday settings. One way to build core skills while strengthening relationships is through serve and return interactions. Brain development during infancy and early childhood is achieved through engaging in interactions with others. This begins the moment a child is born and is often referred to as serve and return. These responsive interactions consist of back and forth between a child and caregiver that literally build the neural networks a child will use for future social, emotional, and communication skills. For example, when an infant or a young child babbles, gestures, or cries, and an adult responds appropriately with eye contact, words, or a hug, neural connections are built and strengthened in the child's brain that support the development of communication and social skills. The Harvard University Center on the Developing Child offers 5 steps in facilitating serve and return interactions. First, notice the serve and share the child's focus of attention. Maybe the child points or looks at something, makes a sound or facial expression, or moves their arms and legs. That is the initial serve. Next, the caregiver can acknowledge their interests, help them, play with them, or bring the object they are looking at closer. The caregiver can now name the object, person, action, or feeling that the child noticed. Continue this process by taking turns, allowing time for the child to respond. And finally, it is helpful to practice beginnings and endings. When they drop a toy or lose interest, you can say, "All done," to demonstrate to the child that you notice they are ready to end that activity. Professionals and families can apply knowledge of child development and the consideration of risk and protective factors in practice to support social emotional development. These practices are important and relevant across the spectrum of services. The provision of IECMH services span the spectrum of promotion, prevention and early intervention, intervention and treatment, and macro level such as policy, laws, and regulations. Each of these does not exist in isolation of the others, and it is imperative that we are all aware of the role and importance of each area. The macro level refers to the policies, laws, and regulations that support health in infant and early childhood development and mental health. In terms of the macro level, there is no single solution to promote infant and early childhood mental health. A work group from 0 to 3 compiled a list of several important approaches to consider at the macro level. These include establish cross-agency leadership for IECMH, ensure Medicaid payment for IECMH services, invest in prevention through mental health consultation, train the workforce on IECMH, and raise public awareness of IECMH. Promotion. Promotion of healthy emotional development focuses on supporting the well-being of all children. It might involve programs to educate parents, caregivers, and providers how to promote social emotional development across early childhood and how to support relational health between children and their caregivers. Areas of knowledge that is important to IECMH promotion include nurturing development, family engagement, and interdisciplinary practice. Examples in practice include educating families and caregivers about the role they play in creating nurturing environments, supporting early childhood settings to provide inclusive, nurturing early care and learning through professional development opportunities and consultation, providing education and consultation to pediatric healthcare settings about relational health and social emotional development. Prevention and early intervention. Prevention approaches, such as IECMH consultation, can help identify and support children who are at risk of developing mental health concerns. Knowledge and skill areas important to prevention in IECMH include understanding child relationships and relationship-based practice, trauma-informed practices, creating pathways to support and partnering with families, developmental diversity, and support. Examples of prevention efforts include universal screening in childcare settings, pediatric offices, home visiting programs, and early childhood programs. Programmatic consultation with early child care and education settings about inclusion, social emotional development, and behavioral supports. Program-wide training in trauma-informed care, positive behavior supports, and relational health for Part C providers, early care and education programs, and other settings that interact with young children and their families, and supportive consultation groups and trainings for families who provide foster care, for example, Circle of Security. Assessment and treatment. Treatment focuses on specialized intervention for infants, toddlers, and families who are already exhibiting symptoms of mental health challenges. Treatment is provided by staff who have advanced training in IECMH. Included in this level of treatment services is the need for developmentally appropriate assessment and diagnosis when necessary. Examples of IECMH assessment and treatment include developmental evaluations completed providers with a focus on functioning across developmental domains, the child-caregiver relationship, and social emotional development. Diagnoses based on the Diagnostic Classification of Mental Health and Developmental Disorders of Infancy and Early Childhood, also known as DC 0-5, and relationship-based therapies facilitated by trained clinicians that focus on the child-caregiver relationship, for example, child-parent psychotherapy. Across the spectrum, there are several key considerations and best practices for approaching care through the lens of infant and early childhood mental health. As we discussed earlier, infants and young children can only be considered in the context of their relationship with others, with their family, community, and in the context of their culture. IECMH services emphasize the importance of using relationship-focused, family-centered, and culturally responsive practices. Additionally, IECMH approaches focus on building from the strengths and values of each infant, young child, and family while prioritizing efforts to prevent potential problems and risk factors. Finally, IECMH approaches to care are interdisciplinary with an understanding that we are all stronger together and families benefit most when we are able to partner across disciplines with the same goal of promoting infant and early childhood mental health. These services can be integrated across disciplines and systems. This includes areas such as childcare and early education, home visiting, mental health, child welfare, the justice system, Head Start and Early Head Start, Part C Early Intervention, Part B Special Education, Healthcare, Public Health, Policy and Legislation, and Maternal Services. Over the past several years, there has been an increased focus on how to integrate infant and early childhood mental health across disciplines and the spectrum of service, from the macro public policy initiatives to prevention and promotion, and through targeted assessment, treatment, and intervention. In Georgia, there has been several recent efforts to push forward the policy and laws to support infant and early childhood mental health. As a result, Georgia Infant Toddler Coalition, convened by Georgia Early Education Alliance for Ready Students, also known as GEARS, which is a nonprofit, nonpartisan research, policy, and advocacy organization that focuses on the needs of children 0 to 5 and their families. GEARS is also a 0 to 3 Think Babies partner in Georgia and provides leadership on infant and early childhood mental health policy in the state. GEARS convened the Georgia Infant Toddler Coalition. In 2018, the Infant Toddler Coalition created a Committee on Infant and Early Childhood Mental Health, which brought together IECMH specialists, healthcare providers, home visitors, nonprofit leaders, state agencies, higher education, and child care providers. In 2019, GEAR supported the Georgia House Study Committee on Infant-Toddler Social-Emotional Health. The committee, chaired by Representative Katie Dempsey, brought together members of the House of Representatives to hear from experts on the needs of young children and their families. Members of the Georgia Infant Toddlers Coalition, IECMH Committee, served as expert witnesses. The House Study Committee provided recommendations to the state to establish an IECMH leadership by housing an IECMH director position at the Georgia Department of Early Care and Learning, also known as DECAL, whose duties include overseeing a public awareness campaign, convening a leadership team from state agencies, connecting with Medicaid and healthcare professionals, and applying for funding to support workforce development. They also recommended to address Medicaid reimbursement and accessibility for children 0 to 4 and extending pregnancy Medicaid to 12 months postpartum. And lastly, to address workforce development by developing an agreed-upon set of core competencies. As a result, Laura Lucas became the IECMH director housed at DECAL in November 2020. The IECMH task force, with child-serving state agencies represented, convened for monthly meetings in February 2021 to address Medicaid reimbursement and accessibility for children 0 to 4 and extending pregnancy Medicaid to 12 months postpartum. Pregnancy Medicaid extended to 12 months postpartum in 2022 legislative session, and mental health services for children 0 to 4 clarified by the IECMH task force in 2022. To address workforce development by developing an agreed-upon set of core competencies, the formation of GA-AIMH and the adoption of IECMH core competencies and endorsement occurred in 2021-2022. Child Parent Psychotherapy Training Pilot occurred in 2021 and expanded in 2022 for a total of 85 clinicians trained. The expansion was co-funded by DECAL and DPH. The public policy changes over the last several years have paved the way for important growth in the area of infant and early childhood mental health promotion and prevention. Promotion and prevention refers to supporting the well-being of infants and young children and their families and helping to identify and support children who are at risk for mental health problems. The following is an overview of some of these efforts in Georgia. Public awareness, trauma-informed communities, helping caregivers and the workforce navigate the system, better understanding early childhood development, training for the early childhood workforce around effective interventions and supporting parents. Promotion and prevention in infant and early childhood mental health is based upon the principle of each and every child having a safe, secure, and nurturing relationship with a caregiver. This video was released by the Georgia Department of Early Care and Learning, and it highlights the importance of individual relationships between a child and a caregiver. To increase public awareness of infant and early childhood mental health, DECAL supports the Children's Mental Health Week, which occurs the first week of May. Also striving to build trauma-informed communities. The goal is to build and expand trauma-informed communities across the state, to create strategies to build a 0 to 5 workforce presence in existing regional coalitions, host community resilience model, also known as CRM, trainings for the 0 to 5 workforce and families in their region, host mindful self-compassion MSC trainings for 0 to 5 leaders, and create an early care resiliency zone guide. To help navigate systems, there are some services and supports that you can access. Connect with resources, training and professional development. There's the pyramid model practices to support social and emotional learning, positive behavior intervention and supports, PBIS, inclusion of children with disabilities. coaching and support for teachers and administrators, guidance addressing persistent challenging behaviors. DECAL is working to spread the word about the importance of ongoing developmental monitoring of young children through CDC's Learn the Signs Act Early program. The Learn the Signs Act Early program was developed by the CDC in conjunction with the AAP to increase the rates of early identification of children with developmental delays and autism. They have developed free resources for families in early care and learning and medical professionals to use to monitor and support early development. All of the resources are available in English and Spanish, and many have been translated into other languages as well. The core of the program is a set of 12 developmental milestone checklists. They can be downloaded in PDF format, or a web version can be viewed at the DECAL Developmental Milestones website at developmental.decal.ga.gov. There is also a free milestone tracker app for mobile devices, which is easy to use, has video and photo examples of the milestones, tips on how to support child development, and the ability to generate a report to share with medical providers and teachers. The CDC released revised milestone checklists in February 2022. The milestone checklist now contains skills that research shows 75% of children do at a particular age. If a child is missing a milestone on the checklist for their age, it is recommended that they may be referred to for a developmental screening. There is an online training for early childhood professionals called Watch Me, celebrating milestones and sharing concerns, which teaches early childhood education professionals to use the milestone checklist to monitor development of children in their care, and how to share information about milestones with families. DECAL offers free child care training credit and a free developmental monitoring starter kit to early childhood education professionals in Georgia who complete the training. If you have any further questions, please reach out to childdevelopment@decal.ga.gov. Infant and early childhood mental health training and interventions. Circle of Security can support child welfare, early childhood educators, early intervention, pediatricians, etc., in their work and with children and families. Georgia-AIMH supported a Circle of Security foster parent training funded by DFCS and a DECAL trauma responsive grant. Support for parents. Evidence-based home visiting, EBHV models, such as Parent as Teachers, Healthy Families of Georgia, Nurse Family Partnership, and Early Head Start, home-based options for parents, individualized supports in the early years of a child's life. Children First collaborates with families, healthcare providers, schools, and other agencies to identify children birth to 5 years old who may be at risk for poor health outcomes and developmental delays. Children First links eligible children to early intervention services, as well as other public health programs and community-based resources. Children First is the single point of entry for all DPH child health programs and services for children birth to 5 years old. All referrals made to DPH child health programs, including Babies Can't Wait, also known as BCW, Children's Medical Services, also known as CMS, Early Hearing Detection and Intervention, and First Care, must be made through Children First. Babies Can't Wait is a part of the IDEA Part C Early Intervention. They serve children birth to 36 months with developmental delays and disabilities in Georgia. Their services includes Individualized Family Service Plans, also known as IFSP, evaluation and assessment, intervention, consultation, and education using a primary service provider model. Children's Medical Services serve children birth to 20-year-olds in Georgia who have medical conditions and whose family income is less than 247% of the federal poverty guidelines. Services include care coordination, family support and linkages to community resources, care of the last resort for medical services and equipment, access to medical home and specialty care clinics, youth transition from pediatric to adult care planning, and travel assistance for specialty care. In addition to public policy, promotion, and prevention, it is also essential to build a network of assessment and treatment options for infants, young children, and their families who have experienced traumatic events and/or are exhibiting symptoms of mental health concerns. Thanks to changes in policies and the generosity of state agencies such as DCAL, DPH, and DFACS, several initiatives related to infant and early childhood mental health, assessment, and treatment have been established over the past 2 years. In terms of IECMH assessment, DC 0 to 5 is the only developmentally based system for diagnosing mental health and developmental disorders in infants and toddlers. 0 to 3 offers both an overview training and clinical training in DC 0 to 5. The overview training provides an overview of the background, approach, and content areas of DC 0 to 5. It is particularly helpful for allied professionals in understanding the importance of developmentally appropriate diagnostic practices. The clinical training focuses on meeting the needs of experienced clinicians, pediatricians, nurse practitioners, and early intervention specialists who specialize in diagnosing and treating mental health disorders in children birth to 5 years old and supporting their families. DCAL and DPH have provided funding for 120 providers to receive the overview training and 100 clinicians to receive the clinical training. Circle of Security is a prevention and early intervention model based on attachment. The founding principles highlight the importance of secure attachment relationships between children and caregivers. The founding principles highlight the importance of secure attachment relationships between children and caregivers, acknowledge the long-lasting impact of poor attachment early in life and later outcomes, and promote safe and secure caregiver-child relationships as a foundation for learning and developing. In Georgia, DCAL, DFACS, and the Infant and Early Childhood Mental Health Consultation, LLC, have provided funding for a cohort of foster parents in Northeast Georgia to be trained in Circle of Security in order to support the caregiver-child relationship and attachment. In infant and early childhood mental health, treatment approaches are typically targeted towards a dyadic relationship between the infant or young child and their caregiver. A clinician is present with the caregiver and child or in a nearby room and coaches the parent to encourage positive interactions that can help improve parenting, the child-caregiver relationship, and the child's behavior. One form of dyadic therapy is child-parent psychotherapy, also known as CPP. The mission of CPP is to provide services that help young children and families recover and heal after stressful and traumatic events. It is an evidence-based, intensive relational therapy model for young children aged 0 to 5 and their families. It is intended for young children who have experienced traumatic events and/or who are experiencing mental health concerns, attachment and/or behavioral problems. Examples include children who have been through scary or painful events such as loss of a loved one, separation, serious medical procedures, abuse, or violence at home and in the community. It can also be appropriate for children with family members who have physical or mental health difficulties or children experiences changes in placement. Being a relational model for intervention, the goal is to support and strengthen the caregiver-child relationship in order to restore and protect the child's developing mental health. The treatment has multiple levels of focus, including contextual factors that interact with the caregiver-child relationship, such as cultural norms or socioeconomic and immigration-related stressors. Through CPP, the caregiver and child are guided to create a joint narrative of the trauma and identify and address trauma triggers that lead to emotional, behavioral, and mental health concerns. The sessions include the child and caregiver, as well as other members of the family as needed. For more information, please visit www.childparentpsychotherapy.com. There has been an effort in Georgia to increase the number of CPP providers in the state. A pilot program trained 15 clinicians in Athens, Atlanta, and Macon, Georgia, who will be receiving referrals from early intervention, Babies Can't Wait, Head Start, and more. A grant from United Way of Northeast Georgia and Community Foundation of Greater Atlanta trained 18 clinicians from 10 counties in Northeast Georgia in spring 2022. The Department of Early Care and Learning and the Department of Public Health are funding 60 more clinicians across the state to complete the CPP training beginning in the fall of 2022. This visual shows a map of counties that will have access to a CPP trained provider as a result of the 2021 and 2022 Georgia-AIM coordinated trainings. Referral sources for CPP include Georgia Pre-K Child Care Programs and Family Child Care Learning Homes, Early Head Start and Head Start, Child Welfare Agencies, Early Intervention, Babies Can't Wait, Home Visiting Programs, IECMH Consultants, Pediatricians, Families, and OBGYNs. Thank you to everyone for participating in the Foundations of Infant and Early Childhood Mental Health training offered through the Georgia Association for Infant Mental Health Birth to 5, also known as Georgia-AIM. To receive credit and certificate of completion for this training, please complete the associated post-training survey. If you would like more information, have questions, or would like to receive updates from Georgia-AIM, please contact us at aimh@gsu.edu. Sign up for our mailing list at www.ga-aimh.org and follow us on Twitter at GA-AIMH.